Hello students. In the continuation of the part 1 of the shoulder joint, today in this session we'll discuss about the different ligaments and the bursa of the shoulder joint. It's a separate short note for your exam. Write the short note on the ligaments of the shoulder joint or bursas around the shoulder joint. So when you will have the ligaments of the shoulder joints, there is a 5 named ligament you will find. Capsular ligament, or it is also known as the fibrous capsule of the shoulder joint. Gleno-humeral ligament, Coracohumeral ligament, glenoid labrum, and transverse humeral ligament. So my dear students, whenever we are reading any ligament, you have to write down the both ends connection of the ligament. That means, suppose this is a one ligament. Now this ligament is having a two end. So you have to write down what is the attachment of the lateral end of the ligament and medial end of the ligament. So let's discuss first the capsule of your shoulder joint. Now when you will have the fibrous capsule or the capsular ligament, again you have to understand that what is the medial and lateral attachment. That means what is the attachment on the scapula and what is the attachment area of the capsule on the humerus. Now it is a loose capsule. Why it is loose capsule? Because it allows the free movements of the joint. Second thing is, it is least supported inferiorly. Now in the part 1 of my shoulder joint, I already told you that this question may be asked in your exam, which part of the shoulder joint is weakest? So always the answer is inferior aspect of the joint. So in this area, the dislocations are very common. Now what is the medial attachment of this capsule? Now when you are talking about the medial attachment, we are talking about the attachment on the glenoid. When we are talking about the lateral attachment, then we are talking about the attachment on the humerus. So when you will see the medial attachment, it is medially attached along the margin of your glenoid cavity. So it is attached on the peripheral margin of the glenoid cavity, but outside the labrum. That means the labrum is present inside the capsule. If you want to see this glenoid labrum, you have to cut the capsule first. Now once you will cut the capsule, then you can see inside, you will find a thick labrum, and that this thick labrum is made up of fibrocartilage. And it also includes the origin of your long head of biceps brachii. Now this long head of biceps brachii arises from supraglenoid tubercle, and here you can see that the supraglenoid tubercle will come here. The long head of the biceps is remain inside till this exit. Now what is the lateral attachment? Now when you will talk about the lateral attachment, we are talking about the attachment on the humerus. Now my dear friends, you know that there is a presence of anatomical neck. So anatomical neck is nothing but it is a junction of the head of your humerus with the shaft. So you will find that your capsule of shoulder joint attached along this anatomical neck. That means that is a line of the fusion of the head with the shaft of the humerus. But there are two areas where the joint is not properly attached. Now one is near the upper end of intertubercular sulcus. You will have a deficiency for the exit of long head of biceps. So when you will see this capsule very carefully, now you will find that there is a presence of a gap. Now you can see that in this gap, there is an exit of the long head of biceps. Because the long head is arising from here, from the supraglenoid tubercle of the scapula inside the capsule. And this long head will exit through this deficiency in the capsule, and then it will pass through this bicipital groove. Clear? And second thing, when you will see the infromedially, you will have the extension which is 1 centimeter below, and it will go up to the surgical neck. So here you can see this is the laxity, and this laxity is going up to the surgical neck of your humerus. Now why the laxity is there? This laxity allows the abduction. If this area is not lax, if you will have this tight capsule, you cannot move the joint. So for the abduction, you need the loose area in the lower part. So because this laxity is there, you can take the, this humerus away from the scapula. So this maximum abduction is possible because of this laxity, which allow the, or you can say it prevents the torning of the capsule, or it prevents the overstretching of the lower part of the capsule at the time of abduction. So in this image, you can see that this is the deficiency, and here you can see this is the long head of the biceps, which is coming out from this gap and it is going downward. Clear? Now, every capsule is lined from inside by a synovial membrane. So it's a characteristic feature of every synovial joint that the capsule lined by the synovial membrane. So this synovial membrane is going to form a tubular sheath around the long tendon of the biceps brachii. So when you will see this long tendon of biceps brachii, along the biceps brachii, a continuation or a tubular-like extension of the sheath is also present, which avoid the friction. So the synovial membrane lines the capsule. So inside the capsule, if I will cut this capsule, you will find that either side is lined by the synovial membrane. But my dear students, this synovial membrane reflects along the intracapsular part of the neck up to the articular cartilage of the humeral head. That means, suppose this is the head of the humerus, and this head is covered by the articular cartilage. This is the yellow color articular cartilage. Now, if I have to draw the synovial membrane on the bone, I am not talking about the capsule, I am talking about the bone. Now, if I have to draw the synovial membrane on the bone, you can draw the synovial membrane only up to the articular cartilage. It is not going to extend on this. If you are drawing the synovial membrane on the articular cartilage, it is wrong. You have to keep in mind that synovial membrane lies the inner side of the capsule. This is the inner side of the capsule. You will have the synovial membrane. But when this synovial membrane reflects on the bone, it is going to margins of articular cartilage. It is not going to cover the surfaces of articular cartilage. So this thing has to be always in your mind, that articular cartilage never covered by the synovial membrane. Synovial membrane goes only up to the margin of articular cartilage. Clear? In addition, there are some openings are present in the fibrous capsule of the shoulder joint, and these allow the communication of the cavity with the surrounding bursa. So you will have the bursas like subscapular bursa, you will have subacromial bursa. Sometimes it may have communication with the infraspinatus bursa. Clear? So when you are talking about the capsule, what you have to understand, that capsule is having medial and lateral attachment. Inner side of the capsule, there is a lining, is known as synovial membrane, and this capsule is loose in the lower part, and in upper part it is having a deficiency for the exit of long head of the biceps. Then you will have the next ligament is glenohumeral ligament. As the name itself suggesting, it is a connection between the glenoid cavity and the humerus. So where is the glenohumeral ligament? Glenohumeral ligaments are 3 in number. There are 3. So this is the one, then you will have the second, and this is the third. So what you are able to understand about the glenohumeral ligament, that glenohumeral ligament present on the anterior aspect of the shoulder joint. But my dear students, these glenohumeral ligaments are not visible in the dissection. Why? Because these glenohumeral ligaments are hidden, or they are lies posterior to the capsule. Clear? Now you can see that if you will draw the capsule here, you are not able to see the glenohumeral ligaments which are lies behind the capsule. Behind the capsule means they are not in the posterior part of the capsule, they are in the anterior part of the capsule, but behind this anterior layer of the capsule. So if I have to see the glenohumeral ligament, the better dissection is that I first remove the posterior part of the capsule, then I will separate the head of humerus, and from inside you are able to see these thickenings, because these thickenings are nothing but these are the inner thickening of the anterior lamina of this capsule itself. So if you are doing dissection from the anterior side, if you try to dissect from the anterior side, you are going to cut the anterior part of the capsule as well as these glenohumeral ligaments. So for the better visualization of glenohumeral ligament, it is always said that you should have the dissection from the posterior side of the joint. So these are the three fibrous bands which derive from the thickening of the anterior part of the capsule. Now see, this is again the important part, that where you will find these ligaments. So they support the joint from the anterior side, so you will find in the anterior part of the fibrous capsule. Now these all three ligaments will converge towards your glenoid labrum, and there is a superior band, middle band and inferior band. Now this superior band is going to attach to the lesser tubercle. Now here, this is your lesser tubercle. So this is the attachment of the superior band of your ligament. Then you will have the middle band. Middle band is again going to attach on this lower part of the lesser tubercle. Then you will have the inferior band which attaches near the anatomical neck of humerus. Clear? So this is the greater tubercle laterally and this is the lesser tubercle anteriorly. So on the lesser tubercle you will have the upper band. Then in lower part of the lesser tubercle you will have the middle band, and the inferior band will approach till your neck of humerus. Clear? Now see, this is your glenohumeral ligament. Is it visible? No. Why? Because I told you that once you are having a complete capsule, you are not able to see. So suppose if you will fade this capsule, or if you will dissect the capsule, as soon as you will fade the capsule, inside that you are able to see these bands. So these bands can be visualized only by doing the dissection from the posterior side, and when you are doing the dissection from the posterior side, you can see the inner thickening, because this is the synovial membrane, and outside the synovial membrane you will have the capsule. So when you are doing the dissection from the posterior side, it is more visualized. Once you will remove the synovial membrane from the posterior side, you can see the thickenings which are prominent feature on the inner side of the anterior aspect of the capsule. Now, this is a question of your exam, that the area between the superior and middle glenohumeral ligament is having a point, and through this point the subtendinous bursa of subscapularis, or you can say the subscapular bursa, communicate with the joint cavity. Now what is happening here actually? Now you have the muscle origin from this part is subscapularis. This muscle is going to insert in the humerus like this on the lesser tubercle. Now to avoid the friction between this tendon of the subscapularis and this part of the joint, there is a presence of a bursa. So if you will remove this muscle from here, what you will find, that here you will find a bursa. Now this bursa is deep to the tendon of subscapularis to avoid the friction. That's why it is known as subtendinous bursa of subscapularis, or it is also known as subscapular bursa. Now this subscapular bursa sometimes communicate with the joint cavity. Now where is the joint cavity? Now this will be your joint cavity. So you know that this cavity is lined by the synovial membrane. So this joint cavity communicate with the bursa, and this, for that communication, there is a presence of a gap. Now this is the gap. Now this gap is present between the superior and middle band. So the site of the weakness in the capsule, which is a common site for the anterior dislocation. Now what is the site of the weakness? This weakness. Now this is the weakness between the superior band and the middle band. So between the superior band and the middle band of the glenohumeral ligament, you will have a foramen that is known as foramen of wet rest. Now this foramen of wet rest is a foramen of the weakness, where you will have a communication of the subscapular bursa with your synovial cavity of the shoulder joint. And sometimes this area may enlarge to allow the dislocation, and that is the anterior dislocation of head of the humerus. Then in this view, in this video clip, we can appreciate this subtendinous bursa of subscapularis more clearly. Here you will find that this is a subscapularis. You will remove the subscapularis muscle. Below the subscapularis, you will have a bursa. So that's why this bursa is known as subtendinous bursa of subscapularis, or it is known as subscapular bursa. Clear? Now you have the next ligament is coracohumeral ligament. Now this coracohumeral ligament extends from the root of coracoid process to the anatomical neck of humerus between the lesser and greater tubercle. So this is the root of your coracoid process. This is your anatomical neck, and on the anatomical neck it is attaching on the lesser and greater tubercle area, and it is providing the strength to the joint from the above. In upper part of the capsule you have a additional support, and that is coracohumeral ligament. Then we will have the glenoid labrum. Now the most important question about the glenoid labrum is that it is made up of, answer is fibrocartilage. So it is a fibrocartilaginous rim, and this rim present along the margin. Here you can see that it is a green color rim. Now this margin is having this fibrocartilaginous rim. Now this cartilaginous rim helps to increase the depth of the cavity. It is triangular in cross section. If you will cut this rim, you will find that it is triangular in cross section. It is something like this. It is attached to the peripheral margin except in upper part. Now in upper part you will have a supraglenoid tubercle. Now this supraglenoid tubercle will give origin to the long head of biceps brachii. So here what will happen, that there is a merging. Now this margin of the glenoid labrum merge with this origin. So some book says that this area is deficient, some book says that this is not deficient, but this area of the rim merge with the origin of the long head of biceps. Clear? Then you will have a transverse humeral ligament. Now dear students, what is happening, that when the long head of biceps will come out, it will pass through this bicipital groove. Now to hold the long head of biceps tendon into its own place, you will have a horizontally placed ligament. Now this horizontally placed ligament is the transverse humeral ligament, which is connecting the two lips of your bicipital groove, and it acts as a retinaculum. Like you have the flexor retinaculum, which are keeping the flexor tendon in their own place. In the same way, this humeral ligament keeping the long tendon of biceps in own place, and it is acting like a retinaculum. So it holds the tendon in its own position. Which tendon? Long head of biceps. Now we'll move to the next point of the lecture, that is bursa related to the shoulder joint. Now when you will see the bursa related to the shoulder joint, you will find two sets of the bursa. Communicating bursa, that means the bursas, those are having the communication with the synovial cavity, and the non-communicating bursas, those are not having any connection with the synovial cavity. So the communicating bursas are more commonly asked in exam. There are three named communicating bursas: Subacromial Bursa, or it is also known as subdeltoid bursa. Second is subscapularis bursa, and the third is infraspinatus bursa. So what is the location of these three bursa? Now subacromial or subdeltoid bursa is in the upper part of the joint, that is below the acromial process. So it is in the upper part. Subscapularis, you know that subscapularis muscle lies anteriorly, so you will have this anteriorly placed subscapular bursa. The infraspinatus muscle is on the posterior side, so you will have a bursa which is infraspinatus bursa. So basically all these bursas are here to avoid the friction between this and the surrounding structure during the movement of your shoulder joint. So what are the communicating bursas? In upper part you have subdeltoid or subacromial bursa. In anterior part you have subscapular bursa. In posterior part you have infraspinatus bursa. Now in this video clip, if you will see the location of this bursa, it will become more clear to you that in anterior part you have subscapular bursa, in upper part you will have subacromial bursa, and when you will go behind the joint cavity, you will have this infraspinatus bursa. So infraspinatus bursa is a posterior feature, This subacromial bursa is a superior feature and this subscapular bursa is a anterior feature of the shoulder joint. So, subacromial bursa is having a very important clinical importance as well as it is more commonly asked as a short note. So, the subacromial bursa separate the acromion process and coracoacromial ligament from supraspinatus. Now, see, its location is a very important question. So, where you will find the subacromial bursa? It is below the acromion process but above the supraspinatus. Now, see, this is a supraspinatus muscle and this bursa is above the supraspinatus. It is not below, it is not here. Please keep this thing in mind that subacromial bursa lies above the supraspinatus because supraspinatus also related with the superior aspect of the shoulder joint. So, you are having the joint here, above the joint you will have the supraspinatus muscle, above the muscle you will have the bursa and above the bursa you will have the acromion process and coracoacromial ligament. Clear? So, my dear students, this coracoacromial arch basically separated from the upper part of the joint and this supraspinatus muscle by a bursa is known as subacromial bursa. So, this is the question of your exam that the bursa lies above the supraspinatus or below the supraspinatus. So, it is outside or above the supraspinatus muscle. So, this bursa prevents the friction between the supraspinatus tendon and the inferior surface of acromion process and this coracoacromial ligament. So, it permits the smooth motion. You do not have any friction during the abduction. Any failure in this mechanism can lead to the inflammation in the bursa. That we will discuss in the coming slide. Now, there are non-communicating bursas also. Now, non-communicating bursas means that they are not having any relation with the synovial cavity of the joint. These lies between the above the acromial process. That means you may have the bursa here. Between the capsule and the coracoid process, you will have the bursa here. You will have deep to the coracobrachialis. So, you will have the coracobrachialis. So, you may have bursa deep. You may have between the teres major and the long head of the triceps. So, you may have the bursa here also. This is the long head of the triceps and this is the teres major. So, deep to that behind the teres major you may have the bursa and sometimes you have the bursa between the latissimus dorsi and the around structure. So, this is the insertion of the latissimus dorsi here. So, around this latissimus dorsi tendon you may have the bursa. So, ultimately what is happening that these bursas become sandwich between the muscle tendons and these are preventing the friction between these tendons of adjacent muscles. Now, this is a very important clinical question for your exam. What is Dawbarn's sign? Now, this Dawbarn sign is related with the subacromial bursa. I told you that subacromial bursa lies below the acromion process but above the supraspinatus muscle. So, in this image you can see that this is your supraspinatus. Now, it lies above the supraspinatus below this acromion process and this is your deltoid. Clear? You can see that this is the deltoid and this deltoid is going towards the humerus. So, this is your deltoid muscle. Now, between the deltoid and supraspinatus, you will have this bursa. Clear? So, this is a subacromial bursa. It is above the supraspinatus, below the acromion process as well as the deltoid muscle. Now, this subacromial bursitis causes pain when the deltoid is pressed just below the acromion process. Now, if I am pressing this deltoid here, and if this bursa is inflamed, which is right now is there, you can see that the bursa is highly dilated right now. So, in this condition, if I am pressing the deltoid here near the origin from the acromion process, if you will provide pressure here, you are irritating the bursa and patient is having the pain, and this condition is when your arm is adducted. You can see this is the normal natural position of the arm, that is adducted arm. But if I will do the abduction, now if you will take the abduction of this arm, what will happen? When you will have the 90-degree abduction And when you will again provide pressure near the origin of your deltoid muscle from the acromion, patient is not having any pain. In this condition, you cannot elicit the pain. Why? Because the bursa has been slipped deep to the acromion process. This is known as Dawbarn sign. Now, this Dawbarn sign is more clearly appreciable in this video. Here you can see that this is the bursa. When you are doing the abduction, the bursa is going deep. You can appreciate this. Again, you can see that if you can do the abduction, the bursa is going deep to the bone. So if I will provide pressure here, the bursa is not irritated. Why you are not able to produce the irritation of the bursa? Because it has been slipped deep to the acromion process. So this is the important thing to understand, that you can produce this sign only when there is a adducted arm. When the abduction is taking place, this bursa slipped deep to the your bony process, and that's why in the abduction you cannot produce the pain. Clear? So this is an important concept for the identify the bursitis in the subacromial and subdeltoid bursa. Clear? So now at the end of this session, you are able to understand that what are the different ligaments of the shoulder joint and what are the different bursas of the shoulder joint. And the important thing is that how to write down in the exam whenever you have this question on the ligaments and bursa. So this is all for the second session of the shoulder joint. Thank you.